Welcome back to Illness Scripts Pencast. Today we are going to discuss reactive arthritis, formerly known as Reiter Syndrome. When we look at predisposing factors for reactive arthritis, we see that these patients are most often young adults, 20 to 40 years old, and more commonly this is seen in men than in women. The reactive part of reactive arthritis denotes that the arthritis is seen following an infection. The two major groups of infections seen in reactive arthritis are enteric infections, seen in about 1% of cases of bacterial dysentery, for example, and non-gonococcal urethritis, the big one, of course, being chlamydia. HLA-B27 is also characteristic in these patients, but it's not required for diagnosis because you only see it in about 60 to 80% of patients that actually have reactive arthritis. Thus, it's not all that useful. The clinical presentation for this disorder is classic for reactive arthritis. First is an inflammatory arthritis, which will present in the history as joint pain, swelling, and often warmth at the same joint. Urethritis will show as pain on urination, or dysuria, and possibly urinary frequency. Uveitis will present as a red, painful eye, plus or minus blurred vision. This triad has affectionately been remembered for generations as can't see, can't pee, can't climb a tree. Exam findings will support the history, with warm, edematous large joints seen on exam. An erythematous eye, plus or minus an irregular pupil, would suggest uveitis. Keep in mind that conjunctivitis is actually a more common ocular manifestation of this disease, however. You will also see a spondyloarthropathy with pain and stiffness of the sacroiliac joints. Enthesopathy, or pain at tendon insertion sites, is very, very classic for reactive arthritis. This is a good time to compare reactive arthritis to another diagnosis on the differential, disseminated gonococcal infection with arthritis. First, disseminated gonococcal infection is more common in women. The arthritis is often classically described as a migratory polyarthritis, where joints will be affected at different times, with inflammation resolving in one joint only to start in another. Though enthesopathy is characteristic of reactive arthritis like we just talked about, disseminated gonococcal infection is often associated with tenosynovitis, so you'll see pain along the tendon rather than just at the insertion points. These patients will often respond to antibiotics as well, given the presence of active infection, rather than simply an immune reaction to a prior infection, as is the case with reactive arthritis. Lab findings will include elevated inflammatory markers, such as ESR and CRP, with elevated leukocytes in the synovial fluid, but it's going to be less than you see in bacterial septic arthritis. It's going to be less than 8,000 cells per cubic millimeter. The culture will also be negative, as this is not an active infection. Thus, an ideal illness script would be a 25-year-old man with recent diarrheal illness, presents with 3 days of subjective fever, malaise, right knee, left heel, and lower back pain, and dysuria. On exam, noted to have bilateral conjunctivitis, warm, edematous right knee, pain on palpation of the insertion site of the right Achilles tendon, with elevated ESR, CRP, and negative rheumatoid factor. Thanks for watching. Remember to like this video and subscribe to the channel if you want to see my other videos. Leave a comment with other topics you would like to see covered in future videos, as well as suggestions on how to improve my channel. Until next time.